welcome back, everyone. Of course, that last report was about schizophrenia, which is, of course, a very serious mental illness. And in the studio with us this evening, we are pleased to welcome Dr. Mohammed Abdul-Jabbar Bardi, who is a consultant psychiatrist. Welcome, Dr. Mohammed.
Thank you so much.
Thank you for being here.
I'm so glad to be being here. Thank you very much for the invitation.
You're very welcome. And if you'd like to start us off by giving us a general description about what is schizophrenia.
Yes, of course. Bismillah ar-Rahman ar-Rahim. Schizophrenia actually is a very well-known mental illness. It affects usually the individual, and it affects his emotions, his mood, his way of thinking, which are the thoughts, his perception, and also his cognition. Schizophrenia is actually, the word schizophrenia is actually derived from the word schism, which is splitting, because what happens is usually splitting of the brain functions, like perception. Perception is the vision, the hearing. Yeah. So the person has splitting in that area, so he thinks that he hears something which is not true, which are called hallucination, which we might talk about later on. Another thing I like to say about schizophrenia is that there's a misconception about it, that some believe that schizophrenia is actually the split personality disorder or the multiple personality disorder that people know. Especially in the Middle Eastern countries, they think it is multiple personality, and that is a misconception. It's not true. Multiple personality disorder is also another known psychiatric illness in our field, but it's very rare. It's even rarer than schizophrenia, and it's different from schizophrenia entirely. So this is basically a brief introduction to schizophrenia.
This is actually the part about misconception, because for up until a few years ago, I thought schizophrenia was multiple personality disorder. What's the reason for the misconception?
True, actually? I think the name has a major role in that misconception, because as we know,
like
schizophrenia, schism is splitting. Also in Arabic, the name is very similar to, because in Arabic it's fusam, which means also splitting, fusam. So people immediately go to fusam means infisam, which is infisam al-shakhsiyya, which is multiple personality. Exactly. So I think that's where it came from. Yeah.
Well, Dr. Mohammed, if you can just tell us about the different types of schizophrenia. There's more than one type.
Yes.
Different categories for different symptoms.
That's true. Actually, the mental illness associations in different countries, one of them is the United States, divided the schizophrenia into types according to its clinical presentation. Of course, schizophrenia is only one mental illness, but they characterize it into different types to help in the management, sort to say, because different types, respond to different type of managements. So anyway, there are about 5 known types of schizophrenia, one of which is paranoid schizophrenia, which is primarily a person has primarily what we called delusions or hallucinations. He has paranoid delusions, paranoid ideas that he is being followed, being observed, or under surveillance, which is, of course, are not true. So that's the paranoid type. There is also one called the catatonic type, in which a person presents to us in the clinic or in the A&E who has symptoms of catatonia. So what is catatonia? Usually it is manifested as rigidity, extreme rigidity and negativism, meaning the person doesn't respond to questions. He has emotional unresponsiveness, so to speak.
So the person is isolated from other people.
Isolated. Sometimes it's so severe that it's like talking to a brick wall. There's no response whatsoever.
And this is just episodes, or all through the day, or?
Yeah, all through the day. All through the day, until they get medications.
Oh, okay.
So yeah, of course, catatonia, this is catatonic schizophrenia. Now, catatonia is also a syndrome that can present with different other types of illnesses, but we're talking about schizophrenia, so that's what happened.
So schizophrenia that has some form of catatonia.
Catatonia. Another type is what we call the disorganized schizophrenia. And here we have the person has mainly generally disorganized behavior, neglecting self-care, neglecting his usual daily activities like eating, drinking. Then there's a disorganized speech. The family or the physicians have difficulty following the patient because there's, a mishmash of speech that you cannot follow. So this is the disorganized type. Then there's one called the residual type of schizophrenia, and this is basically a milder form of schizophrenia. Sometimes patients present to us, they don't have the full-blown picture of the schizophrenia. They have just mild symptoms that we really can't go and say it's complete, full-blown schizophrenia. And usually this happens in the prodromal phase, meaning the initial phase of schizophrenia, just as it's initiating or starting to develop in the patient. And then finally we have the undifferentiated type, and this is just, because if there's schizophrenia that doesn't, a patient who doesn't go under any of the 4 categories will be, or have a mix of all the categories, then he will be characterized by the undifferentiated type.
And because the reason that these categories all arise, is it because of is it just one form of schizophrenia and the person's lifestyle or his personality or how he...
yeah, it's the clinical presentation, actually.
Yeah, but I mean the different types of...
Yes.
The different types of schizophrenia that a person can encounter. Is it just by... is it from the chemicals in the brain, or is it from his lifestyle and his personality and how he was raised?
Yeah, it's probably a combination of both.
Okay.
It could be something, in the brain. It could be the way he was brought.
So it could be genetic or environmental.
Yes, that's true.
I mean,
or a combination of both, actually.
If he grew up spoiled, then if he would have schizophrenia, would he? I mean, if schizophrenia was in the family, I mean, he was susceptible for schizophrenia. And
yes, of course.
He grew up being spoiled and getting what he wanted. Then can we assume that he would get the? You mentioned one of them is the disorganized.
Disorganized.
Is it just from a lifestyle, or is it just?
No, it's more than that. You cannot just judge or characterize by only the lifestyle. It's more than that. Probably it is related to the bringing up of the patient to some extent, but it's really not as clear as 1 + 1 is 2. So it's very difficult to.
Of course.
Yeah, because research have found that spoiled kids. Some of them, a percentage do have schizophrenia and another don't have. So it's not the only reason. They are multifactorial.
Actually, that's what I wanted to ask you, Doctor. What are the risk factors for schizophrenia?
Yes.
How can we, because I know that people can develop schizophrenia much later in life. It can happen much later in life.
Yes, that's true.
So what can we do to prevent it, if anything at all?
Sure. Before that, let's speak about the age. It can occur at any age, of course, but typically it occurs at the early age, usually early adulthood or adolescence, they call it. So between 15 to 25 is the usual age of onset, but it can occur at any age.
That's the normal age.
Yeah, but that's the usual age, the most likely age that it can develop.
So it's very unusual to happen later than that.
Yes, it's unusual to happen later, yes, that's true. But it can happen.
Yeah.
Research has been going on, finding some way to prevent it, and the research is still ongoing. They couldn't find something clear as a preventive measure. However, there are certain risk factors that, one might look at if one wanted to make sure that this patient might develop schizophrenia and might, start preventing it somehow. One of the risk factors, of course, is an early age. So, as we mentioned, we have an early, a young individual. We have to look for the risk factor in this individual. Other risk factors that have been reported are substance addiction. Most likely, hash abuse and amphetamine abuse are the most commonly linked with development of schizophrenia to some extent. So if you have a young individual who is having hash, you might have to put in your mind that he is at risk. Other risk factors are chronic stressful life events. If a person, from his young age, there's continuous stress in his life, this might end up developing schizophrenia. Also, child molestation, child abuse at young age might be a risk factor for this child to develop schizophrenia later in life.
So trauma and drug abuse.
Trauma and drug abuse are the most,
Will they unlock a passive schizophrenia, or I mean, is it something that's in? You said that it can be inherited.
That's true.
But if somebody, I mean, is it a gene that you have in your body that some factors will unlock it?
Yes.
Or is it every human being who goes through trauma or drug abuse will?
As I
will
mentioned,
acquire?
it's multifactorial, and definitely I was coming to that,
Yeah.
another risk factor is actually the family history of schizophrenia, the genetic link. If you have a first-degree relative with schizophrenia, the likelihood of you developing schizophrenia is higher than the general population. So you're absolutely right in that area. Usually the person is carrying the gene for developing schizophrenia, and then the stressor comes in and he goes into developing the full-blown picture.
Okay.
So, but sometimes, you know, a person might be carrying the gene, but he's having not a lot of stressful life, he's not taking substance abuse, so he might be safe from developing the disease or the illness.
Now, Doctor, how big of a problem is schizophrenia in the Arab world, and particularly in the kingdom? Is it a high percentage?
It's, of course, there's some studies that going right now to try to figure out the figure for schizophrenia in the Middle East and in Saudi Arabia. I know that King Khalid, the University Hospital, King Khalid University Hospital are doing research for all mental illness in the Saudi Arabia to know the percentage of each illness. So this would come out soon, the results, and we might know the figure correctly. But to tell you the truth, I mean, we see a lot of patients in our clinics, I mean, really on a daily basis. So I think it might be higher than the West. I'm not really sure. We need to see the figures, but it is a problem in our country.
Okay, but is it like one of the biggest mental parts of the mental illness?
Is it one of the biggest? No,
Yeah.
no, it's not. Fortunately for us and for the patient and for our society, it's not the biggest. No, the biggest would go for depression and anxiety disorders. These are the most common and are really, really very high percentage of patients. They have panic and anxiety as well as depression.
Yeah.
Well, now, Dr. Mohammed, let's talk about the treatment of schizophrenia. You can't cure it, but you can treat it.
That's true. That's
And
true.
the problem with treatment is, well, I'm not going to assume anything. I'll let you just talk about it. What is the methodology of treating
Well,
schizophrenia?
again, you're right in this area that there's no clear cure for schizophrenia. It's a chronic illness. It stays, unfortunately, with the patient for
life.
almost his life. Yeah. So still research is ongoing to find a cure. I hope they find it someday. We will see. But there is treatment. And usually in the treatment we go with the biological aspect of treatment and the psychosocial aspect of treatment. The biological, which include the medication. We use several types of medication that are, you know, coming out. Actually, every year new medication is coming and being developed for schizophrenia. Nothing big or huge came out, but there are several medications that help significantly the patient to resume his normal life and control the symptoms to a high extent. These medications are called the antipsychotic.
Yeah.
Yeah. Some of them have, you know, adverse effects that are troublesome to the patient. So it's really something that
I imagine there might be they might be inhibitors that make the patient feel down, feel drowsy.
Yeah, that's true. Some of them are inhibitors. They're sedative.
Yeah.
You know, they make the patient sleepy all the time if it's high dose.
Yeah.
But I'm sure they're a lot better than they used to be in the old days. I'm sure the drugs nowadays are a lot better.
That's true. Actually, even in psychiatry, we as psychiatrists, we classify the antipsychotic into old generation and new generation. Because there is an older generation that was before the 70s, 60s, and now 80s and onward, there are newer generation with better side effects. I mean, less side effects for the patient, and that's what we're using right now. The problem with these medications is that the patient has to take them daily.
Every single day.
Every single day. And so, you know, a schizophrenic patient who's, let's say, disorganized, he doesn't even care about his hygiene, let alone control his medication. And some of them, they don't have even insight into their illness. They don't know they're ill. They think
they don't.
Yeah. That's
I wanted to ask you about the fact that some schizophrenia patients would actually feel that they don't need the medicine anymore.
That's true.
It's very hard for them to what's the word? I hate it when I forget a word.
Understand.
To accept the fact that they have to succumb to this medication, that they need this medication.
Exactly. That's
true.
So
they feel like, I don't need it. I'm good. I'm great. And then until episodes happen.
That's true. And we call that insight. Does the patient, it's actually in every psychiatrist, when the patient comes to us as schizophrenic, we have to see if he has insight into his illness or not. Insight meaning, does he know that he has a psychiatric illness? Does he know how severe it is? And does he know he needs medication? And the problem with schizophrenic patients is that they lack insight. They don't have insight into their illness. They think they have no problems.
So
They
what do you
believe in
tell the
this.
patient? I mean, when a patient comes to you in the clinic and you ask them about the symptoms and what they're going through, what do they say? Usually they come with a parent, right?
Exactly.
Or with a friend. Or
Most of the schizophrenic patients are brought by their families because they don't know, they don't really believe they have a problem. So
even though they're normal people, I mean, it's not like they're hallucinating or they're living in another world. No, they're living in this world with you, and he knows that he is seeing a psychiatrist.
that's true. That's
But
true.
what does he say?
But regarding the hallucination, some of them actually they lose, the contact with reality. They actually live two different worlds because they do hallucinate. Some of them do hallucinate. Yeah.
Yes.
Do you know the hallucinations which are, they have auditory hallucinations sometimes.
Yeah.
Someone speaking to them, they're alone, there's no one there, they hear a voice. Just like you and I are speaking now, they hear a clear voice. For them, it's absolutely real and clear. And this makes them, confused. What is this voice? What is this world I'm living in?
Why do they hear it? Well, I mean, usually it's always the voices in my head are telling me to do things.
Exactly. When we go into the etiology of schizophrenia, usually it affects the brain.
Is it their
neurotransmitters?
The subconscious talking in a different way, or
It could be. It could be a subconscious, in combination with the biological imbalance in the brain of certain, neurotransmitters, we call them.
Yeah.
The brain actually transmits stimuli that he's hearing something.
Yeah.
Because when we hear something, it goes through the ear, and then the brain says that you're hearing something.
Yeah.
In schizophrenia, the brain says you are hearing something, but there's nothing. There's no stimuli from outside.
Yeah. So they
that's the
basically hear
problem.
their thoughts. I assume maybe, or I don't know.
It could be their thoughts, but it's clear
It's a hallucination.
from the studies. It's a hallucination. It's a clear voice.
Well, Dr. Mohammed, I mean, we're almost running out of time, but I want to ask you a very important question. If a family member or a friend of a schizophrenic patient, let's say somebody with, let's say paranoid schizophrenia,
Yes.
or paranoid schizophrenia is
Someone
it
who
has
is
anger
serious,
and
Yeah,
how
it
do you
can.
deal with a schizophrenic patient that is going through an episode? I mean, if you're with that patient and the patient is getting paranoid and angry, and because in the paper here it says that the symptoms may include anxiety, anger, false beliefs that others are trying to harm you or your loved ones.
Exactly.
In this case, when you're being faced with a schizophrenic loved one who's going through this episode, how do you go about it? I mean, do you calm them down, or do you ignore them, pretend that nothing's happening, or, I mean, just talking to them and telling them, no, you got it wrong, or so and so and so, trying to tell them that no, what you believe is wrong. Does it actually ignite more anger, or will it actually help the person to be subdued, or?
Or should you
Yes.
call your psychiatrist immediately?
I think that's the best way to go with
Can
it.
you really cope with a paranoid schizophrenic?
It's very difficult, and actually a part of the therapy that we give to the patient is also to the family. We have to educate them. But let's say the family started before seeing a psychiatrist. How can they deal with him? Of course, the first thing is do not challenge his ideas. Do not say no, you're wrong. You're imagining things. This will, as you mentioned, will ignite them. Just calm them down. Don't agree with their ideas, but don't challenge it.
Yeah, okay.
Just be calm with them. Try to, we call it, create a rapport with him.
Okay.
Meaning, communicate with him, nice, let him gain your trust, especially that you're loved ones, maybe a father and the mother. And for the family, they should choose the family member that is closer to the patient.
Okay.
So, for example, he's closer to his mother or brother, then he is the one who should talk to him, calm him down, because the patient will be violent, will be aggressive, and then choose some of the symptoms, the minor symptoms. For example, usually they have irritable mood, or depressed mood, or disturbed sleep. So they can tell them, let's go to the doctor to fix your sleep problem, for example, your food problem. Choose something small, not the big picture. Don't tell me you have schizophrenia, just take him to the hospital.
Okay.
Once he's there, then we can take care of it.
and
and start medication and
Yeah.
helping him, and maybe even admitting him to the psychiatric ward for a while.
All right, well, Dr. Mohammed Bardi, thank you so much for being with us and talking with us
You're
about this
welcome.
topic, and we would love to have you on again. and going deeper into this topic and trying to give more awareness to our
That
viewers.
is wonderful.
Most definitely.
I would love that.
And other topics as well, definitely.
I'd love that.
Some
I'd
other
love that.
disorders, some other psychiatric disorders.
Hopefully, I
would be very
appreciate that.
interesting, yeah.
Hopefully, I'm looking forward to that, actually.
Thank you so
very
much,
much.
Dr. Mohammed.
Thank
And we are going to go on another report on schizophrenia, and we'll be back with Engineer Amir Al-Khaldi talking to us on the other topic of the episode, which is exams pressures. Stay tuned.